East and Africa. So from the past years, we have been doing a nonprofit educational webinar every other week to enrich our radiologist knowledge and keep us up to date. So we had various topics across division, and this month we have a neuro theme month. So today, we will have Dr. Lala from Indonesia, will moderating today's session, and Prof. Palacio from Tulane University, USA, as a speaker. He will give lecture about spinal cord infection and inflammation. And also at the end of this session, we will have Q&A. You can write down your questions in the Q&A box. And we also have an online survey to get our certification. At the end of the session, we also have the quiz that will be presented by Dr. Lala. And if you get the answer correctly, 2 consecutive quizzes, you will get the prize. Okay, so we're very excited to have this session, and while waiting the our speaker, Prof. Palacios, I think I'll give the session to Dr. Lala. Thank you very much.
Thank you, Dr. Dita. Good evening from Indonesia. Hello, everyone, and welcome to today's webinar. Thank you all for finding the time to attend this event. My name is Leila Foresta from Indonesia, and I am honored to serve you as your moderator for today. So the purpose of this program is to share knowledge and experience to our radiology colleagues around the globe. It is my pleasure to introduce to you today our esteemed guest, Professor Enrique Palacios, an emeritus professor from Tulane University, New Orleans, Louisiana, USA. He is a neuroradiology and ENT specialist with over 60 years of experience in the medical field and over 200 publications. Tonight, he will be bringing our webinar topic about the infection inflammation of the spinal cord. Is Professor Palacios already here, Dr. Dita?
He's still trying to join. Maybe we can wait for the moment. IT team, can you give the status update right now?
Okay, while we wait, I would like to remind you again that at the end of this session, we will have a few exciting sessions. The first is a quiz session where Dr. Dita has kindly given us a prize. It's a very exciting prize. We will see at the end of the session. And after that, there will be a survey which you can complete to get the certification. I think Professor Palacios is already here, Dr. Dita?
Not yet. But there's like attendees. Oh, is there Carlos Previgliano? You may type in the Q&A or in the chat. Is that you, Prof. Palacios?
Please, Dr. Previgliano, could you type on the Q&A? Oh, yes, this is Professor Palacios, and he's trying to log in, Dr. Dita. Maybe we can wait for him. And about the ARP, what other sessions did you have before this and after this, Dr. Dita? Maybe you can share with us.
Okay, so after the sessions, we will have, I think Prof. Palacios already joined in the, wait. Okay, so.
Okay.
Okay.
Hello, Professor. How are
Good
you
morning,
today?
Prof. Alessios.
I'm sorry, I'm gonna hang up now because
Hi.
Carlos, I'm trying to share a screen.
Okay. Can you share the screen right now?
I'm trying to share this screen.
we can't share the time.
I can't share the screen with you guys somehow.
Awesome.
Can you guys hear me? Okay.
Loud and clear, Professor.
Can you see the Can you see the images on the screen?
No.
I'm sorry, we have no screen.
How do I share the screen? I'm trying to do that.
The lower the end of the screen has the share screen in a green color in the middle. I'm not sure if you see it or not. You don't see it.
I don't see it here.
I think because of Prof. Palacios and Dr. Frevigliano is not the panelist, they cannot share the screen. Maybe
Yeah.
IT can help them to get in.
Well, actually, good morning. I am Dr. Peregrino. I am just an attendee. I am not the speaker today.
Yes, doctor, thank you.
You're very welcome.
But
Dr.
Professor Palacios is with you?
No, Dr.
Yes,
Palacios.
we can see.
Okay. Wonderful.
Am I on? Can you hear me okay?
Yes, sir.
Yes, Professor, yes, we can hear you very well. And your screen has shown up. Thank you very much. Okay, we are very happy to have you here today, sir, and we hope to learn a lot from you about this topic. Well, then
Okay.
let us start. We have 45 minutes for your presentation,
Right.
Professor, which
All
will
right.
be
Thank you
followed
so
by
much.
the Q&A session. Okay, the time is yours, Professor.
All right. Thank you so very much. Good morning from New Orleans. It's a privilege to join in this academic radiology education program. And thank you so very much to Dr. Terpenin and director of this program, as well as Dr. Carlos Privigliano, who always help us, at least some of us, to carry on with these academic activities. So let's go on with the subject, spinal cord infection. I have no disclosures as it relates to this presentation there. So what are the objectives this morning as far as spinal cord infection? We got to identify the risk factors for spinal infections. We're going to discuss the different types of pathogens of infectious diseases that affect the spinal cord. And we'll review neuroimaging of the spinal cord in infectious and inflammatory myopathies. And briefly, we'll discuss that non-infections or inflammatory autoimmune myopathies of the spinal cord may mimic infectious myelopathy. So what are the organisms that can affect the spinal cord? Well, most of them are related to viral, bacterial, fungal, parasitic, and there are some granulomatosis processes such as tuberculosis and sarcoidosis. But viral causes are being the most common pathologies for each will be very dependent on the organism. Now, spondylolisthesis is a subject not related directly to the spinal cord, and are produced by bacterial and arachnoiditis, and sometimes it's iatrogenic, post-surgical, or multiple lumbar punctures, and spinal infection may extend into the spinal cord. All right. Now, risk factors for developing spinal infections include conditions that compromise the immune system. Advanced age, intravenous drug abuse these days, human immunodeficiency, long-term systemic usage of steroids, diabetes mellitus, organ transplantation, nutrition, and malignant processes. Surgical risk factors infections occur in about 1 to 4% of surgical cases. Now, some infections involve the musculoskeletal components of the spine, including the infectious spondylolisthesis, are relatively common. In contrast, the infection primarily involving the spinal cord is a relatively uncommon process, yet very important due to high morbidity and mortality associated with this infection there. Now, as far as imaging, the sensitivity for spinal infections in general is pretty high. 96% sensitivity, specificity 93, and accuracy 94. It's very good in general to the spine. However, in spinal cord infection, the sensitivity is high and the specificity is relatively low. So, neuroimaging can be challenging to diagnose, requiring thorough history, neurologic examination, and laboratory studies with CSF, and in some instances, biopsy to establish a diagnosis. We recognize that there is considerable overlap in imaging appearance of various organisms. Hence, interdisciplinary management is important to improve clinical. So, how about the viruses? The herpes family of viruses include varicella zoster, the cause of chickenpox, herpes simplex, causes shingles, Epstein-Barr virus causes mononucleosis, and cytomegalovirus is common in all ages. So there are three groups mainly in viral myelitis. The herpes family, that one we just mentioned, the enterovirus, which is formed mainly by West Nile virus, poliomyelitis, rubella, measles, and coccivirus. And there is another group, the retrovirus, the HIV, and the human T cell lymphotropic, the so-called HDL type 1. So, varicella zoster causes shingles when reactivated in the dorsal root of the ganglion near the spinal cord, resulting in pale rash. Myelitis may come at the same time as rash, but slowly with a rash in the immunosuppressed. Myelitis caused by herpes virus system is rare in intact immune systems, occurring in those with a damaged immune system, such as severe HIV infection. Case in point here, varicella zoster. Here is an individual here, 76-year-old, with the recent shingles and bilateral lower extremity weakness and urinary retention. You notice here that there is a extensive edema in the spinal cord, and enhancement of the leptomeningeals, following contrast medium there. This is a very, very extensive process here in this patient with the varicella zoster virus. Here's another case of varicella zoster virus. We see some changes in the brain, in the frontal and occipital area, and some leptomeningeal. But look at the spine. There's severe edema in the cervical region, and in the lower portion of the spinal cord, including the coda equina. So this is another case of a meningoencephalitis, myelitis, and polyradiculitis in a patient with HIV. So, in human immunodeficiency virus, HIV, neurological brain and spinal cord complications of HIV are very common during this disease. Some of these complications are due to opportunistic infections as a weakened immune system. HIV itself can attack the nervous system, including the spinal cord. Now, the incidence of malignancy in AIDS. Vacuolar myelopathy is the most severe portion of this disease. It does bear a very poor prognosis when this happens. Opportunistic infections, herpes, CMV, varicella, fungal, and toxo, and bacterial, HIV myelitis, lymphoma, and chronic meningitis. Here's another case here of HIV AIDS myelopathy in a 24-year-old man with insidious and progressive spastic ataxia, paraparesis, urinary retention, and sensory loss. There's a severe extension of edema in the spinal cord in the cervical area, thoracic area, and extending into the conus medullaris. So the MR findings in this HIV myelopathy occurs intramedullary, 24%, intra and extramedullary, 14%, and as a sequela, there is late atrophy of the spinal cord in about 60% of the cases. Case in point here, a 44-year-old male presented with confusion, worsening gait, and progressive spastic ataxia and paraparesis. In these images, we see severe atrophy of the spinal cord in the upper portion of the thoracic area there. So this is an HIV-associated vacuolar myelopathy or AIDS-associated myelopathy. How about the enteroviruses? The best known enteroviruses to infect the spinal cord is poliomyelitis, which has become a very rare in developing countries. Like amyotrophic lateral sclerosis, polio affects the anterior horn cells of the spinal cord, leading to paralysis without sensory changes. West Nile is one of the enterovirus. Can cause neurological disease, including myelopathy. This is commonly found in North America, West Asia, Africa, Europe, and the Middle East. It is a member of the family Flavividae, which also contains the Zika virus, dengue virus, and yellow virus, primarily transmitted by a mosquito, mostly species of Culex. West Nile typically targets gray matter, the spinal cord, producing the lower motor neuron. Laboratory values are useful in the workup of these patients. Suspected West Nile. We have to look for IgM antibody on the West Nile virus and the CSF. This may present with discrete hyperintense signaling intensity in the spinal cord, mimicking transverse myelitis without significant mass effect on the cord. Can span more than 4 vertebral body segments and seen in the sagittal T2 imaging. On post-contrast, leptomeningeal enhancement may be seen in the long segment and often thickening of enhancement of the coda equina. Case in point here of West Nile meningomyelitis. Notice that there is extensive edema of the spinal cord indicated by the arrows, as well as significant enhancement of the leptomeningeals, particularly in the lower portion at the level of the conus and coda equina. Here's another case from the literature where West Nile virus polyradiculomyelopathy is identified in the conus medullaris and chora equina. How about the human T-cell lymphotropic virus type, HTLV1? Most common identified in the tropical regions, the myelopathy caused by this virus is known as tropical spastic paraparesis. Patients present mainly progressive stiffness, weakness of an altered sensation of the legs, as well as difficulty in urinating, developing over the years. This is endemic in southeastern Japan, the Caribbean area, South America, and parts of Africa and Middle East. There seems to be about 20 million people infected worldwide. Most of these patients remain asymptomatic. However, 20% develop rheumatic changes in the brain and myelopathic or tropical spastic paraparesis, predominantly involving the thoracic area. Laboratory diagnosis is based on demonstration of the antibodies in the serum and spinal fluid. Case in point here of a spastic paraparesis with a human T lymphotropic virus type 1. Notice that there is extensive edema in the spinal cord, and mainly in the cervical area. And eventually these patients develop the distal atrophy of the spinal cord. Here's another case. This is a case of pneumococcal meningitis. This is a very interesting situation because most of these patients develop hearing loss, which is a frequent pneumococcal meningitis complications. In this case, you will see enhancements of the leptomeninges, and as well as in the conus medullaris and chora equina. Notice that in this case, there was involvement of the cranial nerves, particularly the 8 and 7 cranial nerves, in this case on the right, which led to labyrinthitis ossificans and hearing loss. Another case of pneumococcus meningitis, you notice that there is a marked enhancement of the leptomeninges involving the lower portion of the thoracic area and lumbosarcal region. This is a meningitis, a very severe meningitis with this extensive involvement, as we see in these images. Bacterial meningitis complicated with a spinal cord infection may occur despite adequate treatment and antibiotic and corticosteroid therapy. So these patients are at risk for ischemia. So ischemia, vulnerability of the spinal cord, is not uncommon in spinal cord infections. Here's a case which eventually developed signs of ischemia, and a patient remaining with a significant residual paraparesis there. All right, let's move to a medullary abscess of the spinal cord. Now, spinal cord abscesses are uncommon. The mechanism of infection is different between children and adults. In adults, it is commonly idiopathic. Identified causes include hematogenous spread and direct spread from adjacent spinal infection. The most common cause of spinal cord abscesses is Staphylococcus aureus. Case in point, the 27-year-old male with a history of cervical myelopathy presented with a paraparesis. And we see in the images pretty obvious changes representing an intramedullary abscess. It's intramedullary pyogenic abscess, As I mentioned before, the most common route is hematogenous. There's another case, a 25-year-old female with severe paraparesis, And we can see here, we see the edema in the proximal portion of the cervical area, and following contrast meeting, you see a ring enhancement of this intramedullary abscess, here's in the axial section, and obviously being an inflammatory process, there is a significant diffusion restriction. It's in this particular case, and day one, we have some focal region here, which has with the contrast medium. 4 days later, now we have a very evidence of an intramedullary abscess, follow up later on, you see the resolving abnormality, although appears to be some sequela from this significant intramedullary abscess. All right. I should mention that infection of the spinal cord are vulnerable as far as ischemia. So ischemic vulnerability of the spinal cord infection is not that uncommon, and we have to be aware of it. In this particular situation here, the anterior horns are mainly involved, which is the motor function. They extend to the posterior routes, the posterior roots, which involves the sensory, and later on involves the white matter, and eventually practically the entire spinal cord is involved by ischemia. So we have to be aware that either clinically or by imaging, the vulnerability of spinal cord with ischemic changes related to vascularis of the anterior spinal artery. In the pediatric group, spinal dysraphism or a neural tube defect may allow a spinal infection. We have 2 cases here, a very large defect here of the spinal dysraphism, and the neural tube defect here, in this other case. This, as we mentioned, may allow intraspinal infection. The most common organisms are staph, strep, E. coli, TB, and occasionally salmonella and brucella. And in this pediatric case, we identified a dermal sinus here, which has led to an infection here, 2 abscesses in the distal portion of the spinal canal with the appropriate diffusion restriction. So this is a bacterial meningitis, and abscesses originated in a spinal dermal sinus tract. It's another case, another pediatric age with a similar history. This is a developed E. coli meningitis, and we can see the extensive involvement of the lower portion of the spinal canal with abscess formation, throughout the lower portion of the thoracic area and lumbosacral region. So this is an intramedullary spinal cord abscess secondary to an infected congenital dermal sinus, which we identify here. How about epidural, subdural, paraspinal abscess, and spinal meningitis? Most of the time by Staphylococcus. Bacterial tuberculosis is the second most common cause, about 25% of the cases. Acute fever and spinal pain, spinal cord compression, and ischemia are the common clinical manifestation, and it should be differentiated from epidural metastatic lesions and extradural hematomas. Case in point here is a lesion here, a cystic lesion. It was thought to be a benign dermal cyst. However, this turned out to be an epidural abscess with a significant spinal cord compression. This is a very, very interesting, a very severe and unusual. This is an epidural abscess which has extended, all the way down to the psoas area there. Notice that there are collections in the epidural space of a pyogenic infection in the cervicothoracic area, lower thoracic, and lombocervical region here. Most of them are in the epidural space, and may extend all the way down, in this particular case, to the psoas muscle here. In these body images, we identified the abscess in the psoas area there, and the sagittal extending all the way down to the inguinal area there. Epidural abscess extending all the way down to the inguinal area. Osteomyelitis as an epidural abscess. We have a case here with a retropharyngeal abscess, but that's created osteomyelitis, disease, and has led to epidural abscess compromise in the spinal cord. 18% of vertebral osteomyelitis or disinfection caused by contiguous spread will develop an epidural abscess. How about the post-surgical arachnoiditis? Case in point here, previous surgery in the craniocervical area has led to this post-surgical arachnoiditis. We see pockets of fluid compromising the spinal cord, as we see in this particular image here in the thoracic region, where we see subarachnoid collections in the spinal cord at various levels. How about this case over here in the craniocervical area there? We see destructive process at the level of a C1, C2, craniocervical junction. This happens to represent a pyogenic infection. However, the differential diagnosis with these images should include rheumatoid arthritis, gouts, Paget's disease, and neoplastic process. Craniocervical junction and osteomyelitis. It's about 15% of the spinal infection. Staphylococcus aureus TB and focal infections are the most common pathogens. There's a common association, otomastoiditis in the pediatric area, retropharyngeal abscess in adults, sepsis, and drug addiction. Case in point here is pediatric case with a history of otomastoiditis, and we can see here in this particular sagittal areas extending at the level of a C1, C2 craniocervical junction, which has led to a significant destructive process of the odontoid and the body of C2. A follow-up examination, we see some resolution, partial resolution on this inflammatory process. We assess the vascular structures to make sure that the vertebral arteries were not compromised. This child eventually had to get surgical fixation to prevent instability. Lyme disease. Lyme disease is an illness caused by Borrelia bacterium. Humans usually get Lyme disease from a bite of a tick carrying the bacterium. Lyme disease in the United States most common in the upper Midwest and northeastern of Atlantic states. Also common in Europe and south central and southeastern Canada. Lyme neuroborreliosis is a neurological syndrome. About 10 to 15% of the cases of all Lyme disease cases manifested with lymphocytic meningitis, cranial neuritis, and radiculomyelitis. Case in point here. This is a case of Lyme disease and neuroborreliosis. These images are very similar to multiple sclerosis, and in fact, in this case, it was thought to be multiple sclerosis, but eventually it proved to be Lyme disease manifested by inflammatory features with a lymphocytic pleocytosis. The patient had a history of a tick bite approximately 4 months prior to these images. So this was confirmed with intrathecal synthesis of Borrelia of the antibodies. Here's another case of neuroborreliosis in a 35-year-old male presented with pain in the right arm, neck stiffness, fatigue, nausea, and vomiting. You notice that there are some changes in central portion of the cervical spinal cord, mostly located in the anterior horns of the gray matter. These patients also develop neuritis of the brachial plexus on the right side. So this is another case, another manifestation by imaging of a neuroborreliosis. This particular case, 2 months later, had a full recovery after treatment. How about neurosyphilis? Neurosyphilis is an infection we all know from medical school, related to bacterial Treponema pallidum. Today, syphilis mellitus is a rare form of the neurosyphilis and requires differentiation from other diseases of the spinal cord, including idiopathic transverse mellitus and spinal cord infarction. There are various stages that we all know from medical school. Meningomyelitis, loss of sensory, progression to ataxia, ultimately to paralysis of the legs. Meningovascular syphilis is ischemic damage to the spinal cord, the so-called avers dorsalis, referring to a spinal cord disorder that develops 10 to 15 years after the initial infection. Syphilis can cause focal growth, gommas, that may compress the spinal cord. Here's a case in point, a 43-year-old woman with sudden onset of weakness of legs. This patient had increased CSF, IgG, and albumin. She also had tested positive for CSF venereal disease research laboratory and CSF fluorescent troponin antibody. This patient had a very interesting finding. There's a focal enhancement at the level of the T7 level compressed in the spinal cord. There was no diffusion and restriction there. Here are the images. There's edema, inhomogeneous edema of the thoracic spine. But there's a focal lesion here, which enhances with contrast medium. And in this particular clinical setting, it was consistent with the gamma compressing the spinal cord. And there was no significant restriction. You can identify pretty much that all these changes, represents or confirm with the syphilitic mellitus. How about tuberculosis spondylitis? Common in the thoracolumbar spine in most cases. Tuberculosis spondylitis disease, most common suggestive features are destruction of the vertebral body with the relative preservation of the adjacent disc spaces. The paravertebral disease and psoas abscess extends to the anterior longitudinal ligament. Case in point here, pretty obvious case, complete collapse of the vertebral body with preservation of the adjacent disc spaces. So this proved to be a tuberculous spondylitis. Another similar case, the significant destruction and preservation of the adjacent intravertebral disc. So this is another case of tuberculous spondylitis. How about this case? Significant changes intracranially, enhancement of the basal system, of inflammatory process, with an abscess in the lower thoracic region, which all this proved to be cranial spinal tuberculous meningitis. In some individuals with history of TB and other parts of the body, particularly in the lungs, may present with these multiple small masses, which represent tuberculomas, and also can be identified in the spinal cord, as we can see in these images. So these are tuberculomas. This particular case is very interesting because it was follow-up with these images, thinking that what we see here in the mid portion, the cervical area, is thought to be a degenerative process, but eventually, without no resolution, this proved to be a spondylodiscitis tuberculous spondylitis. Very unusual manifestation there of a tuberculous spondylitis. How about this one over here, 18-year-old male with a history of chronic pain and radicular pain. There's narrowing intervertebral disc at this level. And on MR, you can see an epidural mass, which proved to be tuberculous spondylitis. You know, this particular case, 70-year-old female, immunosuppressed, it was treated with a prednisone for bullous pemphigus. This patient developed sepsis with tuberculous meningitis and myeloradiculitis, as we can see in this imaging. The patient resulted in paraplegia associated with a neurogenic bladder. Cold abscesses. Cold abscess refers to an abscess that lacks intense inflammation, usually associated with a tuberculosis. Signs of acute inflammation are absent, so abscess is not hot as a typical abscess filled with bacterial material. Cold abscesses are general painless collections in the spinal issues. Case in point here is a cold abscess identified in the psoas muscle on the left side, and this other one here in the paraspinal abscess. These two examples of cold abscesses. It's another example of a cold abscess. You see a calcified mass, in plain radiographs and on CT, and it's a manifestation of tuberculosis, spondylitis, and calcified paravertebral cold abscess. All right, let's move to parasitic infection. Here's a list of most common parasitic infections: cysticercosis, schistosoma, hydatidrosis, toxoplasmosis, trichinella, microfilaria, paraderminosis, malaria, amoebiasis, and strongyloides. Let me review three of them. Cysticercosis is a disease originated from pork tapeworm, mainly involving the brain, but may involve the spinal cord in about 5% of the cases. Schistosomiasis, a common cause of myelopathy. The organisms live in fresh water. People may get infected when swimming in that water. And echinococcosis, Echinococcus canine tapeworm, can cause cystic lesions, hydatidosis, in multiple organs, including the spinal canal. Parasitic infections in the spinal cord are rare in industrialized countries. This is some lesions in the brain, which represents cerebral cysticercosis. As you probably remember, cysticercosis has various stages. This particular stage here is a vesicular. It's a viable larva where we can identify a cyst and a structure inside the cyst which represent the scolex. In the spinal cord is a case in point of cysticercosis involving the cervical cord here, again identifying a central structure which represents the scolex of the cysticercosis. This patient has cerebral cysticercosis presented with paraparesis and which develop over a few weeks. So this is an intramedullary cysticercosis. Is another similar case with the peripheral enhancement. Whenever you see something like this, we have to include other entities in the differential diagnosis, which can be fungal, pyogenic, or sarcoidosis. But this particular case, in a 42-year-old male with a cerebral cysticercosis, represents an intramedullary lesion, intramedullary cysticercosis. Schistosomiasis, three types: the hematobium in Africa and the Mediterranean countries, Mansoni, Africa and Middle East, the Japonicum in Japan and China. It is estimated about 200 million people are infected with this parasite worldwide. The infection occurs in fresh water containing snails, the intermediate host harboring the parasite. So neuroschistosomiasis is an infection of the brain and spinal cord. Case in point here a 24-year-old man with from South Arabia with progressive severe back pain, weakness of lower extremities. Notice that there is extensive and severe edema in the spinal cord, So this proved to be with a high schistosoma titer and IgG and a specific schistosoma antibody to be a neuroschistosomiasis. Long-term intramedullary core edema and high signal intensity is the most common manifestation of a neuroschistosomiasis in the spinal cord. It's another case. This particular case also, neuroschistosomiasis is identified mostly in the conus medullaris, following contrast media some enhancement. There was significant response in the follow-up. This was a 39-year-old man with sensory loss of the right lower extremities, perianal and genital areas, corresponding to a level of T12 L1 sensory level.
Professor, we can't hear your can't see your screen.
Say that again?
We cannot see your screen. And Dida, do you have
Yes,
any problem seeing the screen?
No. The screen is fine.
Okay, thank you. I'm sorry. It's on my side.
Am I okay?
You may continue, Professor, please.
All right, let's continue with this spinal addicted cyst. Epidemiology is in the Mediterranean region, Middle East, Africa, Eastern, part of Turkey, Australia, and parts of South America. Spinal addicted cyst affects any part of the spine, occurring mostly in the thoracic region there. So a human echinocosis is a zoonotic disease transmitted by animals, caused by a tapeworm parasite, the genus Echinococcus. The most common form is a hieratic unilocular cyst caused by Echinococcus involving the spinal cord. Some other manifestations of the body are particularly in the brain and the region of the orbital areas and our liver, but in the spine, case in point here, an extramedullary cyst here, which happened to be a hydatid cyst. It's another case in the posterior epidural portion here, which also represents spinal hydatid cyst. And one more here, with contrast medium, another spinal cyst, which it has the contrast medium, including the adjacent paraspinal muscles here. How about fungal infection? Fungal infection can develop after fungal infection spreads from somewhere else in the body to the brain and spinal cord. The causes of fungal meningitis include coccidioides, histoplasma, blastomycosis, Candida, Aspergillus, among others. Fungal disease infecting just a spinal cord usually occurs in compromised individuals. Case in point of coccidiomycosis, with a significant involvement of the basal cistern, with there's marked enhancements in the base of the basal cisterns. This is an immunocompetent individual, living in an endemic area in the southeastern of the United States. This is a meningitis with paresthesias. Note that there is significant leptomeningeal enhancements in the spinal cord. So this is a coccidiomycosis. Fungal infection. I'm going to a case. This is an unusual case of a sporotrix, typically, which occurs after traumatic inoculation with plants with organ materials here. Here's a case in point of this fungus disease. There are multiple low-intensity nodules, which enhance with contrast medium. All of them in the extramedullary space. There might be some meningeal involvement as well. A case of sporotrix fungal infection there. Brucellosis. Brucellosis is zoonosis with worldwide distribution of about 500,000 cases reported yearly from about 100 countries, distributed primarily in the Mediterranean region, Latin America, Asia, and Turkey. May involve any organ or system, most commonly in the bone joints, central nervous system, as well as heart, lung, spleen, testes, liver, gallbladder, kidneys, and prostate and skin. Brucellosis is a one zoonosis because of a gram-negative bacilli, the Brucella variety. It is acquired by handling contaminated animal products or by ingesting unpasteurized milk derivatives. Multisystemic disease with acute, subacute, and chronic manifestation. Lumbar spine and large joints are most frequently involved. There are two varieties. The focal varieties were involved in disc, inflammatory venous erosion, sclerosis of the vertebral end plane. It can be diffuse spondylitis, osteomyelitis, and adjacent vertebral bodies, including intervertebral discs and epidural extension there. Brucellosis spondylitis may cause spinal cord compromise. So brucellosis can present as granulomatous osteomyelitis of the spine and can be difficult to distinguish from tuberculosis. Case in point here, 50-year-old individual, with some changes in the anterior portion of the vertebral body at this level, with edema of the rest of the vertebra, and this proved to be lumbar spine brucellosis. Another manifestation here at multiple levels of spondylosis, which can be distinguished from other entities, either bacterial or even tuberculosis. How about this one over here? A small collection and abscess with the involvement of the disc as well, also proved to be a lumbar spinal brucellosis. And these are two different individuals, two different cases with an abscess in the epidural space and involvement of the adjacent vertebral body, two cases of cervical and thoracic spinal brucellosis. Another case of cervical brucellosis, identified in the mid-dorsal, in the mid-cervical spine, with edema of the vertebral bodies and a small epidural abscess, compromising the spinal cord. Eventually this patient, had complete resolution of the abscess and very minimal residual in the intervertebral disc. This is a cervical brucellar spondylitis. Neurosarcoidosis is not really an infectious disease. It's a granulomatous process. It's a chronic systemic inflammatory disorder impacting almost every organ in the body, including the CNS. It's characterized by inflammatory process of abnormal cell deposits in the brain, spinal cord, and peripheral nerves, affecting less than 15% of individuals with a sarcoidosis there. Well, in the brain, the involvement of sarcoidosis can be in the Packing meninges or leptomeninges. In the spinal cord, here, these are various examples of a neurosarcoidosis involving the spinal canal and spinal cord. This one, there's enhancement of leptomeninges. There's a mass here in the epidural space, and in this particular case, significant intramedullary involvement. So these are 4 cases of a neurosarcoidosis with significant degree of myelopathies, which occurs in about 2/3 of all the cases. The lesions can be extramedullary, intramedullary, or can be mixed. In the pediatric age, sarcoidosis can be also identified. This is a case in point, where we find, and by imaging, there are numerous macronodular enhanced lesions in the cervical thoracic area. There are some changes also in the brain, in the perivascular, periventricular, and pontine areas. And in this particular case, there was involving of the cranial nerves as well in the 7 and 8 cranial nerves. Well, let me finish up saying autoimmune and inflammatory diseases that affect the spinal cord can be demyelinating process. Among them, multiple sclerosis, neuromyelitis optica, acute disseminated encephalomyelitis, and Guillain-Barré syndrome. It's an example of neuromyelitis optica involving, the uh, uh, the intramedullary portion of the cervical cord. In this entity, there's involvement of the optic nerve and optic chiasm. So this is an NMO, immune-mediated demyelinating disease characterized by visual disturbances and transverse myelopathy. Now, post-infective or post-vaccinal myelopathies, acute disseminated encephalomyelitis, and Guillain-Barré syndrome. Let me show you there, it's 2 examples. This is a case of ADM, acute diffuse encephalomyelitis, and this presents commonly in childhood and young adults, significant changes in the brain. And in the spine, there is a significant involvement of the spinal cord. This is a disease which develops post-infection and auto-triggered by virus vaccination. It's in a case of Guillain-Barré, with a significant involvement of the quina and conus medullaris. This is acute inflammatory demyelinating polyradiculoneuropathy, and clinically is an acute ascending distal paresthesias and paralysis. It's an autoimmune post-infection and post-vaccinal demyelination of peripheral nerves and cranial nerves. And most patients improve in 2 or 3 months, but there is some mortality up to 8%. So, non-specific imaging finding in spinal cord infections, inflammatory, are a challenge to the radiologist. In some cases, clinical course, laboratory values, and multidisciplinary interaction are often imperative to arrive at the correct diagnosis. So my conclusions are, we have reviewed different types of infectious diseases affecting the spinal cord and characteristic of neuroimaging. Primary infection of the spinal cord is relatively rare, yet critically important due to significant neurological morbidity. Spinal cord infection usually is a manifestation of systemic infectious disease. Differential diagnosis and imaging, as well as clinical laboratory values, may be needed to avoid pitfalls. Although imaging features of spinal cord infections are distinctive, non-infectious conditions may present with similar features mimicking infection. In some cases, antibody testing is a powerful tool for the diagnosis of suspected infectious and inflammatory autoimmune myelopathies. So I'm done with this. Thank you so very much for your attention. There's some references there, for if you are interested in identifying more information there. So there you are. I'm done. And thanks so very much for your attention.
Thank you very much for the comprehensive and very interesting lecture, Professor. These are very interesting cases, and your pictures and explanation is very clear. Now it's time for your questions. We have 15 minutes for the Q&A session. And for those of you who would like to ask a question, please write them down in the Q&A box below. I think we already have a question, Professor.
Yeah.
The first one, yes, is from Dr. Harsono from Manado, Indonesia. He is asking, do we need to specifically mention what virus transverse myelitis is caused by in our conclusion in our report?
if I understand the question, how should be reported a transverse malaris and report? That are we saying?
Yes, Dr. Hartono is asking if he is writing a report for transverse myelitis. Do we need to specifically mention what virus is involved?
Well, as I mentioned before, the manifestation and in transverse malaris is a general a description of involvement of the spinal cord. And the causes of transverse malaris are multiple, as we mentioned before. So if we identify changes in the spinal cord with edema, we have described it, and if we have some clinical information or lab, we can actually be more specific as far as the etiology of a transverse myelitis.
Very well, Professor. Thank you very much for your answer. Can we have another question? Here's the second one. How do we differentiate skip lesion, tuberculous spondylitis, and metastasis?
Well, and sometimes it might not be that easy. Obviously, in most cases of metastatic disease, we have obvious clinical signs and other manifestation of metastatic disease. But it can, by imaging, you have to describe it and mention the differential diagnosis, whether it represents an inflammatory process or metastatic disease. But if you have some clinical information, you can be more specific as determined because of the changes in the images.
So the clinical explanation and the laboratory is very important, isn't it, Professor?
Yeah, the clinical findings, we have, obligated to identify some clinical findings to correlate with our images.
Yes, thank you, Professor. I hope that's very clear answer. And for the next question, Professor, how to differentiate between arachnoiditis and epidural abscess?
Well, okay. Well, epidural abscess are focal collections, either a mass or an abscess. They're focal collections. Arachnoiditis usually is more diffuse. Arachnoiditis presents irregularities of the arachnoid or the leptomeninges, and you can identify pockets of fluid which represents, adhesions in various areas of the leptomeninges. It's easy that you can differentiate epidural abscess, which is focal. Arachnoiditis usually is more diffuse, more extensive.
Thank you, Professor. I think we have time for 3 more questions. I have a question from YouTube from Dr. Aurelia. He or she would ask about the difference in MRI imaging findings from West Nile virus with SGB, because SGB can enhance on caudal and conus medullaris also.
Yeah, both the manifestations are going to be very, very similar. Hence, laboratory values and clinical information should be a way to be more specific about it. But the image manifestations are going to be very, very similar.
Thank you, Dr. Enrique. And the last question is about from Dr. Pravigliano. Can we differentiate spinal brucellosis from other infections such as staphylococcus or TB?
Okay, all right. That's an excellent question. Absolutely, that's a very good question. I'm glad it's being brought up because brucellosis it produces very, very similar changes as tuberculosis. However, in tuberculosis, I mentioned before, if the adjacent intervertebrates as well are well maintained, that favors tuberculosis. So otherwise, the changes can be similar and should be differentiated, or should be mentioned, the two of them as the differential diagnosis. And again, the clinical manifestation should be quite different in the two instances.
Yes, so we can write it down as a differential. Yes, Professor. Okay, I think the last question, it's sums our questions. Is there any pathognomonic features in each specific infection that we have to mention in our report? Is there anything specific that we have to mention in our report when we to report an infection in the spinal canal?
I don't follow you. Repeat that.
Is there any pathognomonic features in each specific infection that we have to mention in our
Okay.
report?
All right. Okay. As I think I mentioned, in the presentation, that the specificity of the findings in infection and inflammatory process spines is very low. It's relatively low compared with the infections of the rest of the spine. The sensitivity is pretty high. We can identify these changes, with conventional images. It's very, very easy, but the specificity is very low. And what I tried to do in this presentation is to show a slew of different cases, and all of them, after a while, look very similar. Hence, the differential diagnosis, should be based, when you add the clinical manifestation, laboratory values, and interaction with the other discipline, the infectious diseases department, the neurologist, to be specific, So in some cases, it's very important, to identify the other information, other than images, to be more specific in terms about the etiology of those myelopathies or infectious diseases of the spinal cord.
Okay, thank you, Professor Palacio. Thank you so much, Professor, and every attendee who participated in the Q&A session. That was the last question. And after this, before we close this seminar, we have a quiz session, Professor. May I remind every attendee that those with the highest score from our previous session, from these two questions, will get a prize. That is a Fitbit 5 watch, I hear. Very handy, very fancy. The prize will be mailed to our winner after this webinar. I hope you all do well on our quiz. Okay, let's start the quiz session, Dr. Dita.
Okay, so this is the questions. So from the features above, what is the most possibility diagnosis? Please, for all the participant, you can scan the QR code to answer the these questions, and then it will be 1 minute, and starts from now. Okay.
Please answer in 1 minute.
Professor Palacios, if you prefer or would like to leave the webinar, please do, because it's going to be like our housekeeping things. And if you have things to do, please leave if you want to.
Yes, thank you, Professor Palacio, for your time and knowledge. We hope we can meet again in the future to discuss further interesting cases in neuroradiology, Professor.
Thank you so much.
Thank you so much, sir. Thank you.
I think the poll is closed now for the answer. It's already 1 minute, I guess.
Okay. Can we see the poll, or do we go to the next question, Dr. Dita?
No, this is only one questions, and then we'll inform for the next webinar session.
Okay, thank you. I would like to remind you again that at the end of this webinar, we will have a survey that we would like you to kindly fill and submit. Please complete the survey to get the certificate for this webinar.
Dear ITT, maybe you can share the QR code for the survey. Okay, while waiting, I would like to also mention about our next webinar. So next week, next 2 weeks, we will have the we will enter the cardiothoracic session. So it will be imaging approach to mediastinal mass with the speaker is Dr. Rachna Madan and the moderator is Dr. Adil Mahmoud from Kurdistan, Iraq. So please, dear participant, please scan the QR code for to fill the evaluation form to get the certificate from the webinar. Thank you very much. Thank you very much, Dr. Foresta, for helping us moderating the session.
Thank you. It's been a pleasure.
And okay, I'll see you guys in the next session. Thank you.
Thank you.
I can read these now. Okay. Okay. Hi, Carlos.
Hola, Enrique, estuvo pelea la cosa, pero salió.
Pues, hay medio quebrado ahí con algunos problemas, pero salimos de eso, ¿eh?
Saliste airoso, muy bien, te felicito.